with the small baby. So what about sort of your sex life, and is that getting better as well?
It's getting better, but it's not up to scratch.
Yes, I bet it's only early days, isn't it?
Yeah,
so,
mind you, at least we're getting on better, we're not rowing all the time and everything. When we weren't really rowing all the time, it was just more bickering than anything.
Yeah, that doesn't help, I mean
That's smashing now.
Yeah.
Because if I feel as if I'm going to blow my top, I just get the baby and think, come on, I'm going out.
Well, listen, I think the thing to do you think it helped me talking to your husband a bit as well?
Yeah, he thought, well, it's better not just sort of bottle it all up, you know, because it's always better, because when you were there we couldn't have a row. Well, we could, but it wouldn't look very nice.
A success story? How has Dr. Gardner helped her patient? What can be interpreted from the way they communicate? Liverpool in the 80s, with its empty dockyards and high unemployment, may seem a depressing place in which to practice medicine. Dr. Sheila Abdullah has other ideas.
I'm very optimistic about what's happening at the moment. I think that we're really getting beyond the sort of immediate symptom presentation, and we're really getting at what's happening in people's lives. It's no good just treating this sort of straight physical disease, because you may treat the respiratory infection. I mean, I've just been to see an old man today, and he's got very severe respiratory disease, but the fact that his wife died last night, in fact, and that he's living in absolutely appalling conditions is really, these are the relevant things that we've got to do something about, and hopefully tomorrow I'll be doing something about.
Is a practitioner's determination enough? What resources are there to be drawn upon? Dr. Abdullah's partner, Dr. Katie Gardner.
What agencies we find useful? I think what we do have here is a very good local network. For example, we're in touch with community groups, setups like HomeLink.
HomeLink's an education centre for working class women with young children, and what it aims to do is to provide and promote education for that group, for women with young children. When they do come, we try and put on courses and discussion groups, things like women's health, bringing up children, the relationship between parents and schools, racism in children's books, welfare rights, politics, those kind of subjects.
Local support groups, the attempt to remove social barriers in the consultation, and the determination of the doctors to respond to their patients' social problems. What else can be done in inner city practice?
It's a possible scheme to have a lay health worker attached to this health centre, and that would be very exciting, and I think there's a role for that. I think in some ways, although it may not be the answer, would be to have a sort of geographical, I mean, this would mean a lot of changes in policy, and for example, geographical catchment areas, because one of the problems with our health visitors, for example, which is a disadvantage, they're practice attached, but if they were geographical, and if we were geographical, it would be wonderful. We could just go out into the streets and put letters through saying, come for your smear test, and the health visitors could do a whole area around here. Whereas because they're practice attached, I mean, every other person in the street might belong to us, but the other ones couldn't, and we can't go out and get them. And I think from outreach, for the point of view of actually sort of propaganda and getting people involved while they're healthy to preserve health, that would be a very useful thing to do.
The Port of Liverpool has seen the influx of many different ethnic and cultural groups over the years, and so we have the old established black community, which now is part of resident Liverpool and has been here for 2 and 3 generations. At the same time, we also have new immigrants still coming in, so we have really 2 distinct or several distinct communities. What I think is common to all immigrants, either old or new, are the kind of problems they face in terms of finding appropriate accommodation in terms of housing problems, in developing their education, and all these things relate to how they then are able to use the services that may well be available.
There are 1.25 million people living in Britain with new Commonwealth parentage. These people, along with other ethnic minorities, reside almost wholly in urban areas. Does the health service cater appropriately for these populations? Should we provide special treatment for the ethnic groups? At times, it can be difficult for one sector of the population to understand the experiences of another.
Well, I think the experience of black people has to be seen in the wider context, really, and that is the relationship that normally exists between the providers and the consumers of the National Health Service. And in most cases, you find that there is always a barrier between doctor and patient, and that barrier tends to interfere with communication, which would enable the doctor to see beyond the presenting illness into the crucial link which are lodged in the social and the political side of life. Now, with black people, those crucial links are further enforced by the racism which they experience in all areas of life. And if they go to the health service and encounter racism, which may be overt or even covert, the tension builds up, and they find that the communication system breaks down even further.
The system has broken down for Mr. and Mrs. Naker, patients of Dr. Abdullah.
The Naker family have had a number of medical problems over the years, just straight physical illnesses. But I feel that their position as a combined immigrant ethnic minority group family has influenced the treatment they've received, perhaps, in the sense that I think minority groups experience a difficulty in sometimes articulating what their needs are. Their expectations of the service perhaps are certainly not as great as, for instance, compared with a middle-class family. The actual services often they receive are not always up to standard. Perhaps this was exemplified with Mrs. Naker, who'd suffered with anemia for a number of years before any positive investigations were taken to determine the cause of the anemia.
When Dr. Abdullah took over this case, Mrs. Naker had been on iron tablets for a considerable time. Mr. Naker was suffering from hypertension and a peptic ulcer, and he presented with severe jaundice and subsequent ascites. Unknown to the practice at that time, he was also depressed because of a series of social and personal crises. How do you begin to help a family like the Nakers? Dr. Abdullah recaps the events with the Naker family.
And perhaps we could just look back and think about the things that have happened, because really quite a few things have happened during that time. It was really you, Mrs. Naker, first of all, that I got to know, wasn't it? When
yes.
You came up complaining of tiredness, and you'd been on iron tablets for quite a long time, hadn't you?
Mm-hmm.
And so we decided to look into that a bit further.
Yeah, you sent me for blood tests and that, and found out I was quite anemic.
Yes.
And then decided to give me a smear test.
And you hadn't had a smear test, had you, for a long, long time? No.
Hadn't had one at all. And you found fibroids.
That was really, I think, made easy, wasn't it? Because you were coming to the health centre and we were able to do things for you.
Oh yes, well, Dr. Gary, well, remember, he died. And that's how we came to be in the health centre.
Yes.
And I just went up for a repeat prescription for iron.
That's right.
And
you've been on repeat prescriptions for quite some time, haven't you? Yes.
And you asked me how long, and I said, like, about 2.5 years.
Mm-hmm.
And you said, why? And I said, well, I was anemic. And he just kept giving me tablets.
So we really tried to find out why you were anemic. And yes. And so, really, eventually you had an operation, and you've been pretty fit and well. And then we've had,
marvellous,
unfortunately, the problems with Mr. Naker.
I got better East horses.
Mr. Naker came to Liverpool as a seaman.
Well, at the time I was pretty young and I was able and fit, and I didn't, as I say, I wasn't getting sick all the time. It was just a common cold or something,
Yes.
which went, and I didn't bother going till gradually, eventually I stayed in this you know, as the years passed.
In the late 70s, Mr. Naker's life changed. He borrowed some money to visit his sick mother in South Africa, and when he returned, he found himself out of a job.
When I came back here, I was looking for a job, and I couldn't get a job. And then we had a flood in this place.
Oh, last winter?
Yeah, last winter. We had a big flood and everything, right through all the houses, all over the place. It was like a river, like, you know.
Yes.
And we were forced to, 5 of us, forced to sleep in this living room because the beds were wet and everything was wet.
Yes, I know, it was a terrible time.
That turned me, and then first thing in the morning when I get up and look at the place, I used to get fed up, you know.
And it was very difficult getting anything, any repairs and any help, wasn't it?
We tried, yeah. I've been on the phone, getting the people down.
Yes.
So it was one thing after the other.
So, yes.
So eventually, in the end, like, you know, so I started on the drink, you see, which
Yes.
made it worse.
And then all of a sudden it all overtook you, didn't it?
Yeah.
Because that was something we hadn't realised at all. And then you suddenly became very jaundiced. didn't
Yes,
you?
first I had diabetes to start off with. And from diabetes, the jaundice came on,
Yes.
which was very bad. And when you came down here and seen me and phoned up for the ambulance and sent me down to the hospital.
Well, things seem to have been sorted out quite a lot now, so obviously things should improve quite a lot.
Oh yes,
so,
I've stopped drinking right away. I
Yes.
don't drink no more, like,
yeah, that's good.
and I feel much better for it.
Sheila Abdullah looks at some of the lessons learned from this case.
Mr. Naker, who became ill recently, and in fact we didn't recognise the basis of his illness until retrospectively. And this again reflects the fact that perhaps we didn't know fully what was going on in that family, which would have been helpful. And this is really what we're about when I think we're looking at effective medical care. It's not just seeing the symptoms as they present in the surgery, but looking beyond, because if we'd known a little bit more about what was happening in that family, perhaps things wouldn't have got to the severe stage that they did when the eventual diagnosis was a cirrhosis.
It may be important to understand cultures other than our own in order to provide good medical care. The same symptoms may mean different things to different groups. The same words may have different cultural significance. The problems of language are crucial.
I have 2 daughters in Iran. Tonight I telephone for us. For them. I cry.
Sheila Abdullah again.
We get new immigrant people coming here perhaps with language problems, and so we can refer to the adult literacy scheme, which provides classes both in the home and in groups, and this again breaks down the isolation that many immigrant people will feel and which will otherwise lead to health problems in the end. So this is in ways preventative. So far as the medical problems of immigrant groups are concerned, in my experience, although there can be some specific diseases which are referable to certain cultures, and for instance we found after a recent screening that we find our West Indian population has a considerably higher incidence of hypertension, and the thing that's also been brought to our notice recently has been the problem of sickle cell anemia, which we've been aware of, but I think what we haven't been aware of is the concern of people themselves about the implications of this disease, and this is something we're trying to look at afresh.
How can we try to understand the concern and experiences of groups other than our own?
As soon as you walk in and you find that the whole workforce or the staff is white, that negative feeling is reinforced. But on top of that, if black people walk in and talk to a general practitioner who is not sympathetic and willing to listen to other problems other than the presenting illness, I think a lot of black people still feel the tension and perhaps in most cases interpret that experience as the same as the racism they've experienced elsewhere.
There are a number of questions about race, culture, language and healthcare. What are the answers? A final comment from Dr. Cyril Taylor.
Yes, well, of course, there are no simple answers to all these questions, and many of them in the end are not soluble in the kind of terms that we as professionals or indeed the victims as patients would like to see. There are forces greater than all of us which are being brought to bear and creating these problems. But they are problems and they are challenges, and there are people in need of help. And I feel that we can do much more than is often done within the primary care services to give help. I hope, for example, that with a clinical psychology service within this centre, with our links with community groups and some access to day centre activity, putting people in touch with each other, we may be doing a little more than the ordinary. But quite frankly, unless doctors and other health workers are working in some setting in which there is multidisciplinary activity, they will not only make no impact on the problem, but they will depress themselves beyond belief in the process.
Inner city dwellers are often isolated in the midst of a crowd, and the crowd lacks social cohesion. City centres have always been a magnet for the most vulnerable groups. The doctor or health worker can see this as depressing or as a rewarding challenge.
He loves you like his own son.
Oh, that's very nice of you to say so. Thank you.
In the 4 chapters of this programme, we have looked at some of the problems in the inner cities: the mobile population, people living alone, the lower social classes, and the ethnic groups. Occasionally, it's hard to feel optimistic about some of these patients: the alcoholics, the drug addicts, and the victims of violence. But in most inner cities, one can find hope, enthusiasm, and achievement. Margot Kenyon is the director of the Merseyside Council on Alcoholism.
Yes, we like to think that in Liverpool the services are second to none in the country. There are 2 specialised units in the Regional Health Authority, and there are also a day hospital at the Lakeside Clinic. In addition to that, we also have Henry Cohen House, which is a community-based facility, residential, but we also take daycare people.
Well, the facility that we provide is a sliding sort of programme, normally on a 10 to 12 week basis.